University Grand Rounds. My name is Lowell Kadnick, and we'll be here every Wednesday at 12 New York time to tell you that we are going to essentially cover in 2 years all of vein and lymphatic disease. And it gives me great pleasure to introduce Tomas Urbanek, who will be talking to us on Flebogriff. And then following that, discussants will be Kirsten Schick from Germany and Alejandro Gonzalez from Mexico. That being said, we also have Tobias Hirsch today with us as well, and I'm sure he will then ask some questions as well. So that being said, we have 30 minutes and off we go. Tomas, the floor is yours.
Thank you very much for the invitation, and thank you for giving me this opportunity to be the part of this wonderful educative project. And I think, and I'm sure that we can have a really nice discussion concerning the topic. The device which I would like and the technique which I would like to talk about is right now invented in many countries, however, not much known like laser ablation or radio frequency. We all know the concept of mechanochemical ablation, and it's not just the spasm of the vein and administration of the sclerosing agent, but also some possible influence on the better drug penetration through the and into the vein wall, which at least in theory should give us the better efficacy. But there are also some other points which we can potentially discussed and see in this method, which give us the option and opportunity to find the space for this technology, because as we know right now, the best treatment for our patients is the patient-tailored treatment. So we should adapt our possibilities to the anatomy and pathology which we see. We have this in the guidelines. I'm talking right now about the mechanochemical ablation when a non-thermal, non-tumescent technique is preferred. And of course, there are some medical and also some anatomical indications when we will think about using something which would be non-thermal methods. Currently, two most known methods in the market, it's a Clarivane by Merit Medical. It's a rotational MOCA. With a liquid sclerosing agent, and Flebogriff is another device which is coming from Poland. We use doing this procedure foam and a special design catheter to induce the spasm and also vein wall injury. There are some new projects coming. I think that Professor Kabnik will tell us something about because some new options are on the horizon. But today we will try to answer, do we have the golden standard technique for mechanochemical ablation? Seems that not. We are not sure if we should use liquid and foam. What kind of mechanism of the vein wall injury do we prefer? What's concentration of sclerosing agent? And what should be speed of the ablation? I would like to show you and introduce some experience with Flebogriff catheter. This device is coming directly from Poland, from Warsaw. Our colleague, professor of vascular surgery, Peter Ciostek, was inventor of this device some years ago, and it's his initial series of the patient treated with the device, which at this moment was his original invention. Then, of course, this came to the market as commercially available with a C-mark device. Right now is the name of Flebogriff. There is the special construction of the tip of the catheter with hooks, as you see, which you open, and during the pullback of the catheter, you make the irritation of the vein wall, spasm, and also injury. It's usually the injury of the endothelial layer and some part of the intimal layer. It's a 6 French all-in-one box system with all set prepared for doing the procedure. So you just need the patient dressing and sclerosing agent. How it works, the short diagram for those of you who are not familiar. It's over the wire system. You go to 2 centimeters below the saphenofemoral junction. You open the catheter. You inject the foam when pulling back and getting the vein spasm. Concerning the amount of foam, it's usually 1 cc of foam per 5 centimeter of the treated vein, and for large veins we use rather the stronger concentration. Short video on the procedure is probably one of the fastest venous procedure on the saphenous trunk ablation. So 6 French sheet, wire till the groin, then catheter. Catheter is very well visible. Of course, all we do at the ultrasound. You position the catheter 2 centimeter. It's a catheter, as you can see, very good visibility. 2 centimeter below the saphenofemoral junction. You open the hooks, fix this, and then you pull back the catheter, administering the foam at the same time. So it looks not very, very complex. Of course, some learning curve is needed. What is the advantage of this procedure for the operator? It's over the wire, so you can overcome many problems with this. It's a very stable system, good visibility of the catheter. In ultrasound, there is no mechanical rotation, so you have just the continuous pullback, which you are usually familiar with from the catheter-directed foam sclerotherapy or an tumescent technique. Of course, no tumescent anesthesia and fast procedure. And this what is also important doing this kind. I will show you the data of our study later. For long veins, you can use a really low amount of the foam for the vein ablation, mechanochemical ablation. So here you go with the wire, some steps of the procedure. Then you introduce the catheter on the right side. It's very well visible. Of course, this is the position where we come with the catheter, but you should pull this back 2 centimeter out of the junction to stay away from the femoral vein. The opening of the hooks is quite easy, but remember, you should not push the catheter. You just pull back the sheet, the catheter, like this, and this open the hooks. So do not go opposite. So always the opening is with the sheet withdrawal. And here is the catheter after opening, very well visible, and you stay 2 centimeters away from the saphenofemoral junction. And then regarding the administration, initially this can be something to learn because you have to look on the markers of the catheter, to administer the foam properly. You have the markers every 1 centimeter. And additional markers every 10 centimeter. And you should, of course, close the catheter before removal from the sheet. Some important tips and tricks, as in Clarivein device, sometimes this can be stacking of the vein wall to the catheter. It does not happen very often, but it's possible. Usually the patients start to report pain at this moment. And what you can do, you can close the catheter like this. You close the catheter. You move this catheter 1 or 2 centimeter below, and then you reopen this and you start the procedure again. So this is something which can overcome the patient complaints, if happens, of course. And pullback speed control is something which you have to be familiar with, looking for the markers 1 cc of foam per 5 centimeter of the vein treated. You can treat 60 or even 90 centimeter veins with this catheter. It's a very good option for the patient with some venous leg ulcer and distal puncture for the long axial reflux till the distal part of the cuff. If you want, you can go also retrograde, but then of course the puncture will be opposite side to the normal procedure. When I would not use Flebogriff for the big veins, according to the producer, this is from 4 to 12 millimeters as an indication, but we almost never treat very large veins. For me personally, the good size is from 4 to 10 millimeters. Very angulated vein course, like for all the method, this can be the problem. Remember that we have the very large distance between the cutting element, 27 millimeters, but for the large veins, as all sclerotherapy based technique, it's probably not a good option. So I would not use for the veins like 15 or 20 millimeters. Even if you want to put the tumescent solution around, this will not work properly. And also for the patient where you want so-called crossectomy, so ablation till the level 0 femoral vein wall. This is not that technique. This leaves you always the stump like for the standard laser ablation or radiofrequency ablation with the distance at least 1.5 2 centimeter from the saphenofemoral junction. Post-thrombotic vein, it's also, I think, not a good vein for this kind of technique, because you will have the problem to get the proper vein spasm. Saphenous vein thrombosis, as for most of this method, it's not a good example. And of course, some options which can be difficult to treat. There are the patients with very superficial located vein. We want to avoid the fibrotic cord or hyperpigmentations. And remember that if you try to use this for very small veins, less than 4 millimeters, then due to the huge and significant vein spasm, your catheter can be tucked. That's why for very small veins, rather not a good option. Here are some examples what should not happen. It's hyperpigmentation if you treat very, very superficial located veins, like in some patients after sclerotherapy. You can give foam through the catheter lumen. You can give through the vascular access. You can have the separate puncture, or you can give the foam to the branches when you withdraw the catheter. So various options regarding foam administration. If we speak about this technology, a good option to treat patients with growing neovascularization and the saphenous trunk below, like these cases after previous surgical procedures. Here one example, Flebogriff inside, neovascularization in the groin, and then trunk of the vein, which is incompetent. So first, with the catheter, there is the foam administration.